You're listening to the Cancer Assist podcast, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Wherever you are in your experience, we're here to provide help and hope as you navigate cancer prevention, treatment, and care. Help when you really need it.
Welcome to the Cancer Assist podcast. I'm your host, Dr. Bill Evans, and today we're going to be talking about endometrial cancer or cancer of the uterus with three specialists from the Juravinski Cancer Center. And it's really a delight to have all three disciplines that care for individuals who develop endometrial cancer. Before I introduce them, I'd just like to remind our listeners that the podcast is brought to you by the Cancer Assistance Program here in Hamilton, Ontario. The Cancer Assistance Program provides a variety of free services to cancer patients, including free rides, parking spaces, the loan of equipment of various types like walkers, ambulators, wheelchairs, commode chairs, a variety of different pieces of equipment. As well, nutritional supports, hair pieces, hair, what do we call them, wigs, I guess, and scarves and other head coverings, because not infrequently with use of chemotherapy, people lose their hair. So there's a variety of different things that the Cancer Assistance Program provides to individuals in our community free of charge. And I would want to also mention that the support for this program is brought to you by the Hutton Family Foundation, and we're very grateful for their support to make these podcasts possible. So today, as I said, we have three specialists who deal with endometrial cancer. First, Julie Nugent. She's a gynae-oncologist, a surgeon who is in the Department of Obstetrics and Gynecology at McMaster University and works at the Juravinski Cancer Center. Kara Schnar, who's a radiation oncologist, and Nidhi Kumar Tyagi. Welcome, all three of you. It's great to have you all. Thank you for giving up some time to chat about this particular cancer. And I thought it was important to talk about this cancer because I only recently became aware that it is increasing in incidence, and also its mortality is increasing, and even at a faster rate than the incidence. And that surprised me because many cancers are coming under better control. The incidence rates tend to be generally flat, and some of them are declining. So this one's acting quite differently. So I thought it'd be really good to let the public know more about this cancer so that they're aware and what the symptoms are that might lead to a diagnosis and how it's cared for. So Julie, maybe I'd start with you and maybe just give us a bit of a thought about how individuals who have a uterus, maybe we need to explain what a uterus is too, present when they have this kind of cancer, a little bit about how you go about making a diagnosis.
Good morning. It's an honor to be here. Excellent question. There are a variety of symptoms to look out for. First, we may want to talk about patients who have already entered menopause. So menopause is defined as 1 year without having your menses or your menstruation. So it's not normal to have bleeding after the age of menopause. So if you haven't had a period for over a year and you start to have spotting or bleeding from the vagina, then it's very important to present to care. That does not mean that all postmenopausal bleeding is associated with cancer, but all postmenopausal bleeding needs to be investigated. So patients would first present to their family physician and then be referred to a general gynecologist. Investigations may include ultrasound and a biopsy of the lining of the uterus. The uterus is the womb. It's part of the reproductive system. And for those who have not yet entered menopause, some of these patients can also be at risk of uterus cancer. So it's not only after menopause, although it's more common after menopause. For those who are still having their periods, if their pattern of bleeding is abnormal, so if you're bleeding more than usual or you're bleeding between your cycles, this also needs to be investigated, particularly after the age of 40.
So are there some people, some women who are at greater risk of developing endometrial cancer, Julie?
Yes. So those who have a family history of several cancers in the family, so those may include family members who had early age of breast cancer, ovary cancer, uterus cancer, and colon cancer, may need to be screened. Often their family members will have often already been screened. So those are genetic predispositions called Lynch syndrome. And another important risk factor is what we call increased exposure to estrogen, which is one of the female hormones. Estrogen can come from a variety of sources, such as medications. And another common risk factor is that estrogen is produced by our fat layers. So those who are at increased weight compared to underweight patients are at increased risk of uterus cancer. And then other risk factors include polycystic ovary syndrome, exposure to tamoxifen, which is a medication that patients with breast cancer are on, as well as previous radiation.
So prolonged exposure to estrogen is a risk factor. And so the number of children you have, or if you didn't have children at all, would make a difference because it would be different amounts of estrogen over your lifespan.
Yes. So if you have had more children, then you are less at risk. And then just clarification that estrogen, when given in combination with progesterone, which is another hormone, is safe. So if you're on these medications, you can discuss that with your physician.
And are there any ethnic groups that are more vulnerable or more predisposed to developing endometrial cancer?
Yes. So Black Canadians are at increased risk. That may be as they're at increased risk of some of the more aggressive uterus cancers, but we also believe that there's delayed diagnosis and recognition in certain patient populations. So there are a lot of efforts to increase awareness.
Which is why we're doing the podcast, right? Now, endometrial cancer isn't one uniform disease, right? There's different types of it. So I think maybe 2 dominant types, but I think we're learning as well that it's even more complicated than that. We may not want to go too far down that rabbit hole, but people should be aware that it's not sort of uniformly the same, right? What are the main types of uterine cancer?
Yes, so the traditional way to categorize these cancers were type 1 and type 2. So the type 1 is the endometrioid type. So that's the way they look under the microscope. And those who have unopposed estrogen, such as those who suffer from obesity, will be at increased risk of this type. The second type is more aggressive cells under the microscope. Those include clear cell and serous subtypes, and they're thought to be more aggressive. There are some very exciting research developments over the last few years that can help us even further categorize these types, such that hopefully in the very near future, we'll be able to tailor care and individualize treatments even further.
So that's for another podcast. So you're a surgeon, and I presume you're involved in the diagnosis of endometrial cancer. You mentioned some non-invasive approaches, ultrasound and so on. What do you do, though, to actually get a diagnosis? Because usually we want to look at tissue and to confirm that it's cancer, right?
Very good question. So one of the most important things that patients can do to advocate for themselves is to ensure that they're receiving a physical examination, either with their family physician or being referred to a general gynecologist. Often bleeding from the gynecologic tract is coming from the uterus, but you'll still need an examination to make sure that it's not coming from other organs such as the bladder, the rectum, the vaginal walls, or the cervix. So once you receive an examination, the first steps will be to undergo a biopsy of the lining of the uterus. So this is called an endometrial biopsy.
How is that done?
So this is done in the office. It takes less than a minute. I often say to patients it will take less than 30 seconds.
Oh, wow.
And I usually hold my promise. It's uncomfortable. It feels like a difficult cramp from a period, but it subsides quickly. And this is the way to get a diagnosis.
So you're inserting something through the cervix into the uterine cavity to get some tissue. That's
correct. It's very small. It's maybe 5 to 8 millimeters. It takes less than 30 seconds, and you can take pain medications before and after to make it more tolerable. So that will get you a diagnosis. Will it get you the different types that you were just mentioning, the endometrioid and the serous? Exactly. Very good question. So this sample gets sent to the lab, and then we find out what it looks like under the microscope, and you find out what subtype it is. this is different than finding out this stage. So once we do have a diagnosis of a cancer, then most of the time we will request a CT scan, and this will help us with staging the cancer.
Okay, well, that gets us to staging. So I think my listeners have heard about staging in different cancers. So now you have to tell us about how do you stage endometrial cancer, and how do you tell something about the prognosis from the staging techniques?
Yeah, good question. So we are hopeful that once awareness increases, patients will know to present to care early with bleeding. And so the majority of patients will present with stage 1. So over 80% of patients will present with stage 1. The staging is done in part with a CT scan of the chest, abdomen, and pelvis, and physical examination, as well as surgery if they're candidates. So if the cervix is involved, then patients will be stage 2. And then if there's involvement of lymph nodes or other parts of the abdomen, the liver, the chest, then that makes them stage 4.
Which is where you don't want to be. But is there also something about the amount of invasion of the muscle wall of the uterus that determines prognosis? Did I miss something there?
Yes, exactly. Some of these we will only determine after surgery if patients are candidates for surgery. So the differentiation between stage 1A and 1B can be done with a pelvic MRI or at the time of surgery.
Okay. Oh, before we go to treatment, I just want to ask about this increase in incidence. And you mentioned obesity, and I think everybody's aware that we're experiencing in North America an epidemic of obesity, right? And men and women. So is that a trend in being overweight a factor in why there's an increased incidence of endometrial cancer?
I think that's one of the factors, but there's also an increase in the other subtypes of cancer. So there's a lot of research going on to understand why the incidence is increasing.
So the short answer is we don't really know.
It's certainly playing a role, but there are other factors going on.
Okay. Dr. Schnarr, I think you wanted to make a point.
Yes, I just wanted to help point out for our listeners that in the Hamilton region anyways, that the surgery that's done for endometrial cancer can be done by either a gynecologist or our gynecologic oncologist like Dr. Nguyen. So for once people undergo their biopsy, if it's an early grade cancer, so the FIGO grade 1, and there's no concern that it's outside of the uterus or involving the cervix, many of these surgeries are done by our community gynecologists. So in our region, people all over the area will have surgery, a hysterectomy, and then that will remove the uterus, the cervix, and the ovaries and fallopian tubes. And then they get their stage by looking under the microscope at the uterus, cervix, and ovaries to see where the cancer has spread. And that it is the cancers that appear more advanced or those with more aggressive histologies like FIGO 2, 3, or the serous or clear cell that come to meet our gynecologic oncologists for the surgery. And the Dr. Nguyen and her team do these more advanced surgeries because it requires removing some lymph nodes and sometimes I believe also staging other parts such as the omentum. Is that right, Dr. Nguyen? Yeah. And so as a radiation oncologist, the way it's set up in our region is that anybody who has uterine cancer anywhere, after they've had their surgery, we review their pathology here in Hamilton with our central expert gynecologist. So they may have a read of the hysterectomy specimen, say at the hospital where they had their surgery, and then it comes to Hamilton and it gets reviewed by the expert pathologist. And the way we have it organized is that they'll meet with a radiation oncologist, such as myself, to review to see if there's been any changes, to also review if I think there's a need or what the benefit would be for radiation.
So are you saying that all women who have a hysterectomy and are found to have uterine cancer in our region, which is, Hamilton, Niagara, Haldeman, Brant, Lynn, or formerly called such, are going to have their pathology reviewed centrally?
Yes,
Oh,
yes.
that's really impressive that
Yes.
happens, because that must be a relatively new initiative, because it certainly wasn't existing at a time when I was responsible for the cancer center.
Yeah, I think maybe 10 years. Yeah, I'm not sure how that correlates, or 8 or 6, somewhere. It's definitely more than 2006
That's very reassuring to them, and that there's going to be a review of the pathology, because some important differences in terms of the surgical intervention, as I understand it, that it would be different for serous than it would be for the endometrial type, right?
Yeah,
correct.
Yes. And it's also felt that sometimes these really low-grade cancers don't even require preoperative imaging, and sometimes the surgeons will bring them right to the OR. And then if the pathology comes back still low-grade and early invasion with no risk factors, the CCO guidelines even suggest that the risk of lymph node involvement is low and that we can proceed with either observation or radiation as required or as the risk factors would indicate.
I find this very interesting that the radiation oncologist is explaining the surgery for us here. So but it suggests there's a high level of teamwork here, and there's a group that are thinking about this collectively.
It is also different, as I see all these early cases that come from the community gynecologist, and Dr. Nguyen sees all the advanced, higher stage, higher grade cases. So I also see those cases that Dr. Nguyen does surgery on as well, but there is this population that's managed primarily by our gynecologists.
So I'm going to give Dr. Nguyen a chance to just clarify the surgery here. So there's several things about sort of the extent of surgery and interfacing with the cell type. Like it, from what I understand it, the surgery for the endometrial is, as was just described, it's taking out the uterus and the ovaries and that sort of area, but it's not going further than, it's not taking out the omentum, which is a connective tissue that joins the gut together. That's for the mother type.
That's correct. So perhaps we may want to take a minute to take a step back before getting into the details of the surgery. First, we want to assess if someone needs surgery or is a candidate for surgery.
Always a good thing to do.
Yes. So the first step would be, there are some younger patients who may be candidates for fertility, what we call fertility sparing management. So there are ways to treat certain types of uterus cancers without surgery, such that they can, if they wish, perhaps keep their uterus so that they could carry a pregnancy if they would like that option in the future. That is a very small subset of patients, but certainly an option. There's another category of patients who will not have surgery. Those are patients who are not fit for surgery due to other medical issues or age. And then those who are of advanced stage, such as stage 3 or 4, may not be candidates for surgery. Those with stage 1 or 2, so if it appears that the cancer is limited to the uterus, cervix, and sometimes also if the lymph nodes are involved, then we can offer surgery. Surgery is often the mainstay of treatments for patients with stage 1 and 2, and that includes removing the uterus, fallopian tubes, ovaries, and then those who have a higher risk of lymph nodes being involved. We have very exciting new technology from the last decades that allows us to remove only 1 or 2 lymph nodes on each side. We call that sentinel lymph node biopsy. It's extremely effective. So the detection rate is over 95%, and it has better side effect profile for patients such that their risk of chronic leg swelling or lymphedema is significantly reduced. And then we sometimes also remove the omentum, which is a fat pad that we all have to see if the cancer has spread there. So surgery most often can be done in a minimally invasive fashion, so either with laparoscopy or robotic surgery, and that allows patients to go home on the same day. So it's a very bread and butter procedure with a very low complication rate, and only a very small subset of patients will need a larger incision.
Well, I'm glad you talked about the different ways of doing it. I think these used to all be done open and then became laparoscopic and now robotics. Are we doing the robotic surgery here at Hamilton for hysterectomy?
Yeah, so actually we are able to do, I think, surgery on greater than like 95% of our patients without the robot. The robot achieves the same results as laparoscopy, so really everyone has access to minimally invasive surgery and going home the same day. The benefit of the robot is most often for patients who have a body mass index, so that's a way of measuring their weight compared to their height, of over than 50. So that's usually patients who are over 350 or 400 pounds.
And with the robotic surgery, the benefit is it's less blood loss, and you can somehow manage the surgery better with these individuals who are heavy.
So the outcomes of laparoscopic and robot are the same for patients in that they can go home the same day, and the incisions are very small. The robot just allows you to have certain angles and better access in those with an elevated body mass index.
Fabulous. Well, getting educated here. So now go back to radiation. From my reading, radiation doesn't have a big role in this disease, but it does have some role. And maybe you can tell us how often it's used, in what circumstances it's most appropriately used, and when it's not.
Yeah, so we'll say that the curative aspect of treatment is the surgery. And so radiation plays a role in reducing the chance of it coming back most commonly. And there have been studies that have looked at the role of radiation, in particular in these earlier stage cancers, because some of the lower stage cancers, they're less likely to involve the lymph nodes and less likely to spread to other parts of the organs. And in fact, one of the big trials, the PROTECT-1 trial, found that the most location of recurrences is actually the top of the vagina. So even though everything's been removed, they found a certain subset of patients would have a risk somewhere of 12 to even 20% of it coming back at the top of the vagina. Now, with that risk, there's been further studies done to look at how is the best way to give radiation to these patients. And another big trial found that using a local radiation, such as vaginal vault brachytherapy, which is a simple cylinder inserted into the vagina, they can target the upper 3 centimeters of the vagina, can lower the chance by 2/3 of the recurrences in the upper vagina.
Okay, I think I'm going to take a break there, and we'll be right back.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist podcast possible. The Cancer Assistance Program is as busy as ever, providing essential support to patients and their families. We remain committed to providing free services for patients in our community, including transportation and equipment loans, personal care and comfort items, parking, and practical education. These services are made possible by the generosity of our donors through one-time gifts, monthly donations, third-party fundraising, corporate sponsorships, and volunteer opportunities. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
So just before the break, we were talking about brachytherapy as part of the treatment for certain stages of endometrial cancer. So maybe it's a good place to just go back and repeat that a bit and explain brachytherapy, because I'm sure a lot of our listeners won't really understand that.
Yes, for sure. So I guess I'll just maybe piggyback on the brachy conversation, that what I was just saying before, that the studies showed that of people that recur, 75% of the recurrences of these early grade or low grade cancers happen at the vagina. So there are some people that I meet after their surgery, and I assess based on the pathology results, or basically what it looks like under the microscope, that the chance of this cancer coming back is so low, at less than 5%, that I actually don't recommend any radiation. No chemo is recommended. In fact, the surgery was all they needed. And those patients then can be surveyed. And what surveillance looks like is a pelvic examination every 6 months for 3 years, and then yearly to year 5. And part of the pelvic examination and the surveillance, is very important to have somebody looking and feeling the vaginal tissues. Because if these cancers come back in the vagina, it can be a small little plaque that could bleed, or maybe not bleed. But by inspecting the vagina and feeling, you can pick up these recurrences.
That sounds like the follow-up should be done by someone specialized, like a gynecologist, gyne-oncologist.
Yeah, so it's if there's no radiation, no chemo, then whoever did the surgery can do this follow-up, and then I quote them a risk of 5% or less. Now, for the intermediate group, where the risk is like 12, 15%, in that range, I'll offer the vault brachytherapy. And this is a local radiation to the top of the vagina to lower the chance of the recurrence. It's a cylinder goes into the vagina. you're awake. It's not painful. It is a bit, I mean, it's not a standard thing that one has done. So sometimes I say it's a little bit of pelvic pressure, but other than that, it's well tolerated. The side effects long-term are fairly minimal, and most people do really well. And it's sort of an insurance treatment to help lower the chance of this cancer coming back.
So this cylinder contains the radioactive material.
Yeah, well, sort of. So the cylinder is just a smooth plastic-like cylinder that inside has channels. So we pick the cylinder that best fits the person's vagina size because I want it to be nicely in contact with the vaginal mucosa, not having any folds and not painful for the patient. So I insert this cylinder, we fix it into place so that it stays at the top of the vagina because the top is the spot that is the most important. And then we connect it to what's called our afterloader that holds this radioactive seed. And then we leave the room. The radioactive seed is programmed to come out of its sort of safe box and then in through the cylinder, and then it delivers a dose of radiation to the upper third of the vagina. Treatment time is about 10 minutes. Following this, the seed goes back into the afterloader. The cylinder comes out, and people can go home.
That's it?
That's
10
it.
minutes?
10 minutes.
Oh, wow.
You're not radioactive. You don't need to fast. You don't need anesthesia. You don't need pain meds. It's a fairly easy treatment. And side effects, there are some risks of long-term side effects, mostly some narrowing of the vagina or some abnormal blood vessels that can form after radiation. But really, patients do quite well with this treatment.
Well, that's very important to understand. I have no awareness of that. So that was a great explanation and should be very helpful to those who are potentially going through this procedure. Now, but then there's external beam radiotherapy, and what role does it have?
So when the risk of recurrence becomes higher to the point that I think that there's now a chance of recurrence in lymph nodes or the pelvic side walls, basically all the places where the uterus used to be. So the ligaments that held the uterus in place or the lymph nodes that the uterus would have drained to in the upper vagina, when the risk approaches 20% of the pelvic recurrences, we start to get a little bit more concerned about other areas of recurrence. And that's when I would use my external beam radiation because it allows me to pay radiation to more places in the pelvis. So it gives us a greater risk reduction. So I can target the lymph nodes, the pelvic sidewall or these ligaments, and the upper vagina. And then that is given in a fractionated course by radiation from the outside. So the external beam radiation.
So that's multiple treatments.
Multiple days. 25 is the standard treatments. 25, a little bit of radiation each day. And this one has a bit more in terms of side effects because to get at the lymph nodes, there's some bowel, bladder, rectum. You have to go through more of the body to get that. And
so that's what we would call adjuvant.
It's still adjuvant. It's still an insurance treatment to lower the chance of the cancer coming back. Yeah.
Was that ever given with drugs?
Yeah, so that's a great question. So when we start to think that now the risk is getting quite high or it's one of these higher risk histologies, so serous or 503, or now we're seeing with the mutations or
Did you say 503?
FIGO.
FIGO.
Sorry.
Sorry,
I should explain that. FIGO is the Federación International Gynecologic Oncology. It's how we characterize them under the microscope. So the more higher grade cancers I've been found on studies to benefit from chemotherapy as well as radiation because we know that they're a little bit more likely to seed off into other spots outside of the pelvis.
We should let a medical oncologist explain this. So Dr. Kumar, maybe you could do that.
Absolutely, yeah. So thank you. So like Dr. Schnarr was mentioning, when the risk becomes higher and a concern of, say, disease spreading elsewhere in the body, we want to do a little bit extra after surgery and after radiation. So that's where chemotherapy can play a part. We're learning more and more about these endometrial cancers to understand what type of endometrial cancer needs more treatment and where a person would benefit from more treatment and where there may be areas where we can scale back and may not need to use chemotherapy. And those are some prospective trials that are ongoing at this time. But briefly, if somebody has, say, even a stage 3 cancer, so there's lymph nodes involved, and the risk is high, that there's a high risk of recurrence, we then talk as a team, in a multidisciplinary team in a meeting, to assess what type of treatment we can give. So there are several studies that look at both concurrent, so chemotherapy and radiation together to enhance radiation effects, and then chemotherapy afterwards. There are other trials that look at radiation first, then chemotherapy afterwards. And there's further studies that are also just looking at chemotherapy alone. So this is a area that has a lot of discussion, and that's where our team comes together to see what suits the patient best, depending on the stage, the person themselves and their past medical history, and also what's been seen under the microscope.
It sounds like there's a lot of ongoing research, so it's not as clear as it could be or should be, perhaps, as to which patients should get additional radiation. Do any of the studies show differences in either local recurrence rates or overall survival?
Yeah, we do see, mainly as a retrospective study, so that means looking back at a study, that there are certain subtypes of endometrial cancer that even with, say, chemo, radiation, or just radiation alone, they did very well. There was very low risk that this cancer came back, and when we followed them along for 5 years. So right now, there's a thought that if those patients with these certain changes in their tumor, are they the patients that may not need all of that treatment, and they may do well with just radiation or just chemotherapy? So at this time, that's a question that needs to be answered, and there are several studies that are ongoing internationally to answer that question. So it's an exciting time for endometrial cancer because it's now no longer one size fits all for that person. Instead, it's becoming more personalized based on what we're seeing under the microscope and the different testing that's being done on the tumor. It's also going to be more personalized to the person in front of us and what their other history is and how they presented and what we feel is the best recommendation, weighing risk and benefit of the treatment.
Sounds very thoughtful.
It is. That's one of the things that is really unique about this approach and management of this cancer is that we are always collaborating with each other, with our surgeons who also give chemotherapy here at the Cancer Center, with our radiation oncologists, just to ensure that we are really thinking through the next steps for our patients.
Typically, the role of the medical oncologist is to treat people who have advanced or metastatic disease, and that's almost totally the purview of medical oncologists, so sometimes other therapies can be required. So maybe just talk a little bit about, first of all, patterns of metastasis in this disease. Where does this cancer go from the uterus? We talked about going to lymph nodes, but does it go to the lungs, the bone, the liver, the brain, or what does it do?
Yeah, great question. So when there is a recurrence, so that is when, several years after, say, a surgery, that there is certain areas of the body that the endometrial cancer does tend to metastasize to or spread to. And those areas include the lymph nodes in the pelvis, the omentum, so that area of fat that Dr. Nguyen had mentioned. It can also spread to the liver and then also the lungs. So those are the most common places that we do see.
And in that setting, what are your choices for, you say, systemic therapy that can go through the whole body systems?
Absolutely. So that choice also becomes a very personalized choice again. So looking back at a person's history. So did they have radiation after surgery, or did they have chemotherapy and radiation after surgery? And then also understanding the timeline. When was that chemotherapy completed? It also depends on the patient themselves and their symptoms and their overall, what we'd call performance status. How well are they feeling at this time? And then finally, it also depends on certain genetic changes in the tumor that we learn from their biopsy or their surgical specimen that can help dictate what our first line of treatment is. So briefly, it is chemotherapy. That still is the standard of care, which shows the most benefit. There are some new studies showing us that if a tumor has certain changes, that we can also add in immunotherapy as well. So that's been an exciting change.
Is there a role for any endocrine therapy in this cancer?
Yeah, there can be a role for endocrine treatment.
Maybe it's old-fashioned because that's what I remember from early days.
No, absolutely. Yeah. So it really depends on, again, under the microscope, is this a type of cancer that uses estrogen to help it grow? So more in keeping with, say, a lower grade endometrioid type endometrial cancers that don't have any other aggressive features, that we think there's a good rationale or prediction that endocrine treatment can help control this cancer. We also would often reserve endocrine treatment for those patients that have what we consider low volume of disease. So not a lot of disease that's spread elsewhere in the body, and where the patient is largely asymptomatic from their treatment. Because we know endocrine treatment can take some time to take effect. It takes time to control the cancer as opposed to chemotherapy, which can act relatively quickly.
The thought of chemotherapy, I'm sure, frightens a lot of patients because of the side effects that may happen with it. The particular drugs that you use, what kind of side effects could a woman expect from them?
Absolutely. So a person who's being treated with the type of chemotherapy that we use, it's usually a 2-drug chemotherapy. Often we give pre-medications beforehand that can really help manage those side effects that a lot of people are concerned about. So the most common side effects that I tell my patients is nausea, which is actually well controlled with our pre-medications that we give. And we also give medications to take home if they're having nausea. We also counsel them on fever and risk of infection. So often that is well controlled as well. And we do have a mechanism of seeing our patients if they do have a fever quite quickly. Unfortunately, hair loss is part of a side effect that a patient will experience. Oftentimes hair does grow back after chemotherapy is completed. And then also fatigue, and that can be usually in the first week of chemotherapy, and then there's a slow recovery between the cycles that we give.
You mentioned how the genetic basis of the cancer is changing, and also how immunotherapy is starting to have an effect. And I gather there's a couple of agents, immunotherapy drugs, that are being used. Maybe you could talk about that, how you select patients, and maybe what kind of testing is now possible to look for some of these mutations that may be eventually targeted specifically, like we do in some other cancers.
Absolutely. So right now, all of our endometrial cancer samples, so biopsies or the surgical specimen, what's been removed at surgery, are being tested for mismatch repair genes. And these are genes on the tumor itself, and we want to understand whether there's a deficiency in those genes. So are they lacking a certain function? That function is to repair DNA, and if there's a gene that's missing, then that means the repair of our DNA is flawed. And we know that when a tumor has these genes that are deficient, they're also more likely to respond to immunotherapy. So if we can just imagine that normally in all of our cells, and unfortunately in also cancer cell, DNA is being doubled. And in that doubling process, there's mistakes that are being made. And when mistakes are being made, the tumor looks very different to the normal cells. And a tumor looking different to our normal cells helps our immune system recognize that tumor as something foreign and start to kill that cell. And that's a way of killing the cancer itself. So our immunotherapy, specifically pembrolizumab, has shown some benefit in endometrial cancer when used after chemotherapy to help control the cancer. What immunotherapy does is essentially takes off the blindfolds of our immune system and says, hey, there's something here that's abnormal. This tumor should not be here. Start attacking this tumor like our immune system should be doing. And that's what pembrolizumab starts to do.
It's a neat analogy of taking off the blindfold.
Which the cancer cell has done.
Which it does very effectively. It's knowledge we've gained over the last, I guess, decade or so about how cancers are smart enough, shall we say, to avoid the immune system. And now we have an understanding of how we can trick them again and make it possible to attack them. So it sounds like the field is changing because it was... I would say probably a cancer that was neglected in some respects over time in terms of research and looking for genetic markers and mutations and so on. But that sounds very encouraging. Maybe you could just say a bit, perhaps both of you, about research that's going on in the Hamilton area, or what you see as important trends in research generally for this particular cancer.
So I think, I think the first trend that we're really excited about is like what I mentioned, what we'd consider like escalation trials. So who are the patients that need after surgery, radiation, and chemotherapy? Who are the ones that are going to benefit the most from both of those modalities? And then alternatively, there are also de-escalation trials. So those who will do well even if we don't give them chemotherapy, or will do well if we don't give them radiation. So I think that's a critical trial that is ongoing nationally and internationally. And we also are a member of the international group that is running that trial. And we're hoping to open up a trial at the Juravinski Cancer Center that will look at that question itself.
So very much tailoring the treatment to the extent of disease or the risk of recurrence.
Absolutely.
One shoe fits all.
And tailoring to the molecular subtype.
Yes.
Yeah. So even before, if you saw somebody that had a certain stage, you might think to offer the treatment based on the stage. But now that we understand molecular subtypes, we're seeing there's this one in particular, the POLA mutation, that actually may not need any adjuvant treatment, even for the slightly higher stages. So a trial to sort of de-escalate. Of course, we have to do de-escalation trials like properly with close observation and everything, but to see if we could help to identify patients that may not get as much benefit from treatment and then follow them closely.
Often the trend in oncology in the past was more is better, be more aggressive, but there has been the trend first, I think, in perhaps surgery to back off, and lesser degrees of surgery shown to be as effective in many cancers as a more aggressive intervention. So it's made the side effects of cancer care less by virtue of this kind of tailoring process. But it does require people to get together and talk about these things. As you mentioned earlier, multidisciplinary clinics and tumor boards. Maybe you could just elaborate a bit on that, what actually happens on a weekly basis, so that patients and our listeners generally have an awareness of how oncology specialists are working more together rather than as individual practitioners.
So often it's done over Zoom, and we review pathology and the images as well. So radiology, a CT scan, a pelvis MRI if needed. And really, we come together and ask the question, well, do we consider this person high risk enough to use treatment such as radiation or chemo? Or say, and a lot of my questions that I bring are for patients who have advanced disease. So, we've worked on one, they've been given one treatment, and if things are working, then is there options for other treatments, or would they be a candidate for, say, radiation, even in the advanced setting for areas that may be growing? So those are some of the questions that we discuss.
I think our DST is very multidisciplinary. We share clinics, we share patients, we interact with each other a lot, and that allows us to have lots of different conversations about cases that are more challenging. So our multidisciplinary weekly discussion that Dr. Kumar Taggi was just describing, we all had the opportunity to put our challenging cases on for a discussion. But then even in addition to those cases, we have lots of interactions and back and forth between each other about our cases and our shared patients, so that we can really ensure we are, offering just the best treatment, and also that, we're optimizing all aspects of care. It's one thing I really like about being part of our gynae group in Hamilton is that with clinics together, if say a patient comes in that's only supposed to see me that day, but I see something concerning, I go out, and my clinic is like my other colleagues that also follow that patient, and I'll, grab Dr. Nguyen and say, hey, can you come and look at this? I have a worry, or Dr. Kuwartag, and I do that a lot too. And so it just allows, I think, better care. It's also more satisfying as a provider to be, to feel that integration with your colleagues.
I think it's very reassuring too for patients to know that that's what's happening.
Yeah, we really are
getting the input from different people who have different perspectives, but you're reaching a consensus of what would be the best for an individual.
Yeah.
Does that also engage any of the individuals, the gynecologists in the wider region? Can they join you?
Yes, yeah, they do join our multidisciplinary.
It's a great education opportunity as well. So we do discuss with the challenging patients, we talk about what's the evidence, what can we draw on, and it also brings up gaps of when there is not evidence to help guide our treatment. Is that an opportunity to be creative and think about new trials, or to reach out to our other partners in other centers to say, what is the best approach here? Because as you mentioned, endometrial cancer, although incidence is rising, and it's not one of the bigger sites where there's a lot of trials, and that's definitely changing now. There's been an explosion of clinical trials looking at new ways of treating this disease, but we're still waiting on those results. So we do want to be as creative and innovative with the best evidence that's available.
I've previously done a podcast on clinical trials, and always like to encourage patients who are presented with that opportunity to take advantage of it, because it's at the very least you're getting the current best treatment. You may be getting a current best plus something else that's even better, and so that's a potential benefit. And you get very close supervision in a clinical trial, and overall patients in clinical trials seem to do better than patients who are not in clinical trials. So just a word to anybody listening who might be presented with that option by one of their mine oncologists to take advantage of that.
And I just want to give a little shout out to our pathology and radiology colleagues, because in these multidisciplinary groups, we really rely on their expertise, and we have fabulous gynae expertise in pathology and radiology at our center here in Hamilton. And in fact, all of these new clinical trials are very pathology, I would say maybe labor intensive, but pathology in depth, because all of these new molecular subtypes, it's all pathology that's giving us information, and then we as the clinicians are determining like the downstream treatments. But we really rely and appreciate the work of our pathology colleagues. And then on the flip side, our radiology our colleagues are just their ability to read pelvic MR. We've really come a long way with imaging and MR in particular. So some of our advanced cases, I rely on the expertise of my radiology colleagues to read these MRs and give all of us the understanding of what's happening in the pelvis. So I feel very fortunate to work in such a great team.
So multidisciplinary isn't just the disciplines that treat cancer, but it's other disciplines that diagnose it and contribute to the decision-making in that way. One of the reasons we do these podcasts is to make people aware of just the nature of how decisions are made for cancer, and particularly to showcase the talent that exists in Hamilton to diagnose and treat cancers, to give the public confidence that if they are unfortunate and have a cancer, they are fortunate to have excellent resources here to provide care. I think we've covered this very well today, and I really want to thank you for your contribution. Just as we wrap up, just to remind listeners that these podcasts are available on Apple, Spotify, all your usual places, plus the Cancer Assistance Program's website at cancerassist.ca. And it may not be relevant for you to listen to one about endometrial cancer, but there are about 60 podcasts that cover virtually all cancers and various supportive care elements. So you may find one that's most relevant to your situation or your loved one's situation. So please take advantage. I want to thank Dr. Julie Nguyen, the gynae oncologist who contributed so much of the diagnosis and staging and surgical management to our discussion, and Dr. Kara Schnarr, who's a radiation oncologist, for contributions, and Dr. Kumar Kiag. I really appreciate your input, and it's been terrific talking to all of you, and I think our listeners will have benefited greatly from your expertise. So thank you all.
Thank you for having us.
so much.
Thank you.
Thank you for listening to the Cancer Assist podcast. Find more episodes, resources, and information at cancerassist.ca, or follow the Cancer Assistance Program on Facebook, Twitter, and Instagram. Thanks for listening.